Lung cancer, as you know, is number one, extremely common and highly lethal. Lung cancer is really a disease of exposure, and the classic exposure is tobacco. But in North America now, most lung cancers, especially most lung adenocarcinomas, which are the most common subtype of lung cancer, are in non-smokers or never smokers. And that means that it's other exposures in the environment that must trigger this.
Welcome to Your Body, the healthcast that takes a deep dive inside your health. No matter what kind of health issue you're experiencing, whether it's the common cold, a bad case of eczema, heart disease, or breast cancer, it affects you in every way, physically, mentally, emotionally, and internally. This podcast seeks to understand what is going on with our bodies from the inside out, from our heads to our toes, and everything else in between. We're going to look at health issues from every angle and hopefully get a better understanding of what's going on with our bodies and how we can better take care of them. I'm your host, Stephanie Landon, editorial manager at RadNet, a leader in outpatient imaging services and an advocate of patient empowerment for over 35 years. Could that cough be telling you something? Take a breath. Inhale. Feel that? That's your lungs at work. They bring oxygen into your body and send carbon dioxide out. This process of inhaling and exhaling takes place 12 to 20 times per minute. The lungs are the major organs in your respiratory system, and they affect every aspect of your body and health because the oxygen they take in travels into your bloodstream and circulates throughout your entire body. Interesting fact, your lungs also help you talk. There are many conditions that affect the lungs, but in this episode, we're talking about the most significant one, lung cancer. Lung cancer is the second most common cancer in both men and women, not counting skin cancer, and it's the leading cause of cancer death in the United States. Each year, more people die of lung cancer than of colon, breast, and prostate cancers combined. On a positive note, the number of new lung cancer cases continues to decrease, thanks to more people quitting smoking and advances in early detection. But at the same time, the numbers of lung cancer cases in non-smokers or never smokers have been slowly increasing. I think that in general, whenever we hear about lung cancer, it's just scary. And the statistics aren't really giving us reason to think otherwise. The American Cancer Society predicts that in the year 2023, there will be almost 240,000 new cases of lung cancer and about 127,000 deaths from lung cancer. So what I want to know, what I think we would all like to learn, is what can we do? How can we prevent lung cancer in ourselves and our loved ones? How can we just breathe?
He walked in and he goes, "Hey, good news. In the past, we could have maybe kept you alive 2 or 3 years, but now with these new drugs, we can keep you alive, like maybe 8 or 9 years." And I remember thinking, 8 or 9 years? I have a 7-year-old.
Yeah.
And I just was right then and there. I was like, screw that. I'm going to do much better. And I'm coming up on the 8 years, and I'm going to blast right through that.
I'm talking to Marissa Moisey. She's a lung cancer survivor, having been diagnosed almost 8 years ago. She was not a smoker, had never smoked in her life, but by the time her cancer was diagnosed, she was at stage 4. According to the Centers for Disease Control, 10 to 20% of all lung cancers happen in people who never smoked, or who smoked fewer than 100 cigarettes in their lifetime. And as I said in the opening, There are studies that indicate that this number is growing.
Honestly, looking back, there were probably quite a few symptoms that I kind of ignored because I had 4 young children ranging from 15 to 7. And I was a busy mom, and I was running around. And, you know, I would kind of cough on occasion. I actually was a jazzercise instructor at the time. And I was noticing that I was getting short of breath when I was teaching my classes.
Mm-hmm.
And that should have been a huge red flag. But I just charged ahead. And I thought, oh, well, I had been diagnosed with asthma as a small child.
Right.
And I always had bad allergies. My asthma kind of went away as I got older, but I thought, oh, well, that asthma's come back.
That it probably wouldn't even have occurred to you that could be what it was.
No,
yeah,
absolutely not. It was not on anybody's radar. I grew up in Tucson, and I always thought if I was ever going to get cancer, it was going to be melanoma.
Right.
Because I grew up in the sun. I mean,
right.
Lung cancer, absolutely not on my radar. I never smoked. I've never liked cigarettes. I can't stand being around people smoking. So yeah, I was like, okay, this must be asthma. And then things progressively got worse. And then, so I was diagnosed in May of 15, probably starting around this time of year. I probably had 3 bouts of bronchitis. I just kept getting sick.
Ugh.
And that's when I finally thought, gosh, I really need to go in and see a pulmonologist.
Yeah.
And, you know, I called to make an appointment, and they would not see me until I had to come in with a chest x-ray, with a pulmonary function test. I think, I'm trying to remember, maybe there was one more thing, but I remember I called and I was like, really?
Right.
That's annoying. That's asking a lot of me. So I blew it off. So,
right.
you know,
Right.
a little bit more time went by, and
Right.
I finally went in, got that pulmonary function test done, which I passed with flying colors, which again should have told me right then and there it was not asthma.
Right.
So I was like, well, that's weird. What the heck? Because I was convinced it was asthma.
Yeah.
So my husband is an orthopedic surgeon, and I called the pulmonology office back, and I said, hey, is it okay if I just get a quick x-ray in his office?
Mm-hmm.
And they said, sure, because I didn't want to go through the hoops of the hospital. I knew my husband could get me in right away. So I popped into his office one day. I was like, hey, can I just grab that chest x-ray? And he said, sure. And I still remember he put it up. He has these like light boxes where they, you know, read the x-rays.
Right.
Like right in the middle of his clinic. He puts a picture of my lungs up there, and there's this huge circle. It looked like a golf ball. I mean, anybody could see it.
Yeah.
I mean, I'm not a nurse who knows how to read x-rays, but I could see there was something there.
Right.
And still nobody thought lung cancer. We're all going, what is that? My husband, his PA, myself, we're all sitting there looking at it going, well, that's weird. What is that? And I thought, again, I probably was just getting over another round of bronchitis. I thought it was like a glob of mucus. I mean, it's so dumb looking back, but I was like, gosh, that's weird. But at this point now I had what I needed. I got into the pulmonologist, and, you know, we're talking, and he said, well, gosh, maybe you have valley fever. And I was like, yes, of course. I mean, I grew up in Tucson. It's common in Phoenix and Tucson.
I'm going to just interject really quickly. For anyone who doesn't know, valley fever is an infection caused by a fungus known to live in the soil in the southwestern United States, for example, Arizona, as well as in parts of Mexico, Central, and South America. Having not lived in these areas myself, I wasn't really familiar with valley fever until I looked it up. But apparently you get it by breathing in the microscopic fungal spores that are in the air. Most people don't get sick or have symptoms, and a lot of people recover on their own. But there are some people who require medication and others who have long-term problems in their lungs from valley fever. In Marissa's case, it was unlikely that it could have been valley fever because she hadn't lived in Tucson for years. She lives in Flagstaff, Arizona, which is up in the mountains and not in the valley.
At that point, the pulmonologist said, we need to get a chest CT, which we did.
Okay.
And that's when he saw, he said, gosh, you have a okay, why am I drawing a blank? A lymph node. I had a lymph node that looked irritated. And then he's like, yeah, that would make sense with an infection.
Wow.
And he said, I'd like to do a lung biopsy. And I was like, well, I don't need a lung biopsy. That's stupid. Why do I need that? Because I was so in denial that it could be anything serious.
Right.
And, he said, well, you can go ahead and we'll test you for valley fever, but it's probably going to take about 2 weeks. I was like 11 to 14 days to get the results. He said, we'll send off those labs. And in the meantime, let's do a lung biopsy. And I was like, I had one scheduled and I canceled it. And I said, I'm just going to play this really conservatively. Let's wait on the valley fever results first. And, then those, by the time those came back,
right,
all of a sudden things were starting to spiral. I was starting to cough all the time. It was starting to really hurt when I coughed, and I was kind of doubled over. I was kind of leaning to my left side because I was in so much pain. And when the valley fever came back negative, I was like, okay, yeah, something's really wrong. So I went to that biopsy, and then that's when I got the news. And when he told me you have adenocarcinoma, I laughed. And I was like, well, what's that? Some benign thing? And I'm a nurse. I know.
Right.
But it's just, 8 years later, I'm still just laughing about how in denial I was and what a shock it was. Mm-hmm. And the next words out of my mouth, I never smoked. This is impossible.
Right.
And, and again, I feel badly because as time goes on, I feel badly for people that there's such that stigma. Oh, you smoked and you did it to yourself. I don't even think that's fair anymore. So I asked him, I said, well, my gosh, I never smoked. And my mom pipes up, she didn't grow up in a house where anyone smoked. How is this possible? And even he was a little unclear. He's like, well, I guess radon gas. Oh. And I did not know anything about radon gas. I was even a chemistry minor. I knew it was somewhere on the periodic table. I couldn't tell you anything.
Right. And
I said, well, what's that? And he's like, well, it can be in your house, but he's like, yeah, it's kind of more like back in Pennsylvania. And I said, yeah, okay, well and my husband and I looked at each other and I said, I'm sure we don't have radon gas in our house. We just assumed. And again, we were totally spitballing. We just assumed maybe that was part of a home inspection.
Right.
Oh, I'm sure when we had our house inspected, they looked for radon gas.
Right.
Nobody knew anything. So anyway, we did then test our house, and we lived on a kind of the side of a hill. So we had a walkout basement.
Okay. And
radon gas generally will accumulate in a basement, but ours wasn't even a true underground basement. But we went ahead and did the testing, and the levels weren't crazy high. They were a little higher than the EPA recommends.
Okay.
But they were there. So that's really all I can figure. That's the only thing that I could maybe point to. But
that's so crazy.
Because then I got nervous because my kids were always playing
sure.
dumb. I'm like, oh, great. Everyone's been, exposed to this radon gas.
Yeah.
But then I told all my neighbors, I said, hey, everybody, you need to test. And it was really interesting. We were in a cul-de-sac, and the houses to the right of us had nothing. And the houses to the left had levels higher than we did.
Oh, wow.
Kind of wild.
How
how it tracks through the ground, and then, then it kind of seeps up from the ground. And then if your house is over where it's escaping the earth, it'll build up in your house or your, basement or crawl space, whatever. Anyway, but nobody else in my cul-de-sac got sick, just me. So I don't think that everybody who breathes in radon gas necessarily is going to get cancer. I think it's a combination of factors. And looking back, I prided myself on kind of being healthy. I was a jazzercise instructor. Right. I ate pretty well. I made sure my kids had vegetables at every meal, but I was a terrible sugar addict. I was constantly buying candy. I had all these stashes to hide it from my kids. I would kind of get through my day with a lot of sugar. I love to stay up late. I had some kind of unhealthy habits looking back.
Right.
Like to drink some wine when I was cooking dinner. You know, I probably was, and
Yeah.
that's sugar, right? Alcohol is straight up sugar.
Right.
And so, and I probably at that point didn't have good grasp on my emotions. I was emotional. I fought with my kids. I was a super perfectionist. I was trying to control my children really hard. Especially my oldest son, we clashed a lot. I was trying to make him be somebody that he wasn't, and we were always clashing. So I had a lot of emotional turmoil in my life. I would say now I'm in therapy. I've been working on it for a while. But I think it was just kind of like, I was like a powder keg.
Right.
And then that radon gas was the spark, and, you know, boom, there you go. And maybe I already had a tendency towards lung disorders because of that childhood asthma and lifelong allergies. I don't know. My mom actually had adult onset asthma.
Oh,
There's
interesting.
asthma in my family. So, I mean, who knows if that plays a role, but
yeah. I feel like they're just realizing they're, you know, like, I feel like that they're just sort of trying to figure out if there's a genetic component to lung cancer. So,
right.
So what stage were you at when you were diagnosed?
Well, initially the pulmonologist guessed 3A. And again, I was kind of laughing. I don't remember learning in nursing school that it would be A or B.
Right.
I didn't realize if you have two of an organ, like kidneys, lungs, ovaries, it can be A or B, meaning, you know, it's one.
Oh, okay.
It's one lung or both. I was like, 3A, what does that mean?
Right.
And then when they went in, after the biopsy, I had to go in again, and they put a camera down right in that little notch at your collarbone.
Oof.
It's called a mediastinoscopy.
Okay.
They popped a camera down there, and they found another big lymph node on the right side. So my initial tumor was on the left.
Okay.
And I had this big lymph node on the right, and I think maybe one in the space between two. I can't remember exactly, but that bumped me to stage 3B. So initially it was like, oh, it's probably 3A, and hey, we're just going to take out a little chunk of your lung and you'll be fine. That was kind of what I was told.
Right.
You know, 3A, have a little lobectomy, send you on your way. Okay. Well, then a few days later, oh shoot, no, you're 3B. So now you're going to have to do chemo and radiation. And I was like, oh, great. Because I had a terrible fear of chemo and radiation.
Yeah.
So I was really psyching myself up. And the first day I went into Huntsman, and they were going to start with the radiation, and I had to be fitted for some kind of mold.
Okay.
Because the lungs are always moving, kind of like your heart. They're not still. And so when they do the radiation, it's hard for them to get it in the exact spot because the lungs are moving. So I'm being fitted for this mold thingy, and they found another tumor. And, you know, it was freaky. Everyone got really quiet. There were a lot of people in the room, and everyone got really quiet, and I heard some whispering. I was like, oh, crap,
That's never
what
good.
now?
Yeah.
Yeah. And then all of a sudden, you know, they're giving me a gown and telling me to go in this room, and this radiation oncologist comes in, and she just was like, I'm so sorry, you're stage 4.
Later in this episode, you'll hear me speak with oncologist Dr. David Hoffman about some new findings in lung cancer treatment, wherein people with certain gene mutations are able to avoid chemo and radiation and instead take medication. Marissa was fortunate enough to be one of these people, and she told me that within days of starting medication, she began feeling better. Nearly 8 years later, she's still on this medication, and she's still feeling great.
I approach my life as though I am already healed, and I'm just taking this medicine for fun.
Right. Yeah.
That's my mindset. I mean, of course, I still take care of myself, and I'm cautious. And, you know, during COVID, I was cautious.
Yeah.
My oncologist early on, he's like, well, you know, you've got this lung thing. I don't know how this is going to affect you. So be careful. And, you know, but I'm still cautious, but I live as though I'm totally healed. And every day I happen to be a religious person. You know, I pray every day. I give thanks to God for my healing. And, I always was religious, and I probably even went a little deeper after my diagnosis.
Right.
But, you know, I just think that your outlook and your mindset are huge.
Yeah.
And in addition, I supplement, I'm very, very grateful for this medication. I supplement it with a really healthy diet. I've really cut back the sugar. I mean, it was really out of control. I really watch it with the sugar these days. I don't eat red meat anymore.
Mm-hmm.
I mainly stick to chicken, a little fish. I don't eat a lot of dairy. There's a lot of things I do to supplement my healing, and then just trying to reduce my stress level. That's easier said than done.
I hate that cliche that like in some ways it's a blessing, but I wouldn't say that. But it definitely sounds like it gave you a different perspective. That's
absolutely no. I actually do feel like it was a blessing. When you're faced with your own mortality, you start to think about, how do I want to be remembered? I mean, I really made an effort to just be a better person, and again, be more grateful for what I have, and just live my life with more integrity.
I'm Elizabeth Walton. I'm the Executive Director for the American Lung Association in Arizona. I'm based here in Phoenix, Arizona, and oversee pretty much all things lung health that we do throughout the state.
After speaking with Marissa, I started thinking about the air we breathe and the possibility that living in our modern world, going about our daily lives, inhaling, exhaling, day after day, could ultimately make us sick. That's crazy to think about. So the first person I called was Elizabeth Walton from the American Lung Association in Arizona. The Lung Association is a national organization whose mission is to improve lives and prevent lung disease through education, advocacy, and research.
We do a lot of advocacy work, particularly in the air quality space, especially in Arizona, because we have some of the worst air quality in the country.
Oh, wow. That's interesting. And have you found that that is a contributor to lung cancer?
It's a contributor to all lung disease.
Mm-hmm.
Obviously, everything that we're breathing in is affecting our lungs. And so the Phoenix metro area has the 5th worst ozone levels in the country. We also have the 8th worst year-round particle pollution. So that's particulate matter, that's PM 2.5 that we're talking about there. And so these are microscopic particles that people are breathing in, and they're, people who already have lung disease, who are already affected, this definitely has a huge impact on them. But it really impacts all of us.
The American Lung Association recently released their State of the Air report for 2023, which analyzes the air quality throughout the country, not just in Arizona. In its findings, the report states that there is some progress in our overall air quality thanks to decades of cleaning up sources of air pollution and to the Clean Air Act. The report says that overall, there are 17.6 million fewer people breathing unhealthy air in the United States compared to last year's report. Still, nearly 36% of Americans, that's 119.6 million people, still living in places with failing grades for unhealthy levels of ozone or particle pollution. The State of the Air report is broken down by state, county, and city. And if you want to check out the air quality where you live, you can visit their website at www.lung.org. So what kind of steps do you take at the Lung Association in terms of, advocacy for that?
So our air quality work goes back a long way. We were actually really involved and pretty instrumental in getting the Clean Air Act passed in 1970. So we had a big 50-year celebration a couple of years ago. And, that made major strides in the air quality improvements that, that we've seen over the last 50 years. Sure. However, we, especially here in Phoenix area, which is the case for a lot of big cities, LA, San Francisco, California has some of the worst air quality as well. in other major cities across the country, you have a lot of people, which means a lot of driving, a lot of pollution from emissions. So we do a lot of work in the electric vehicle space as well on different coalitions and with different groups, because we know that there are steps that can be taken to make a difference. And, it's just a matter of, again, educating people on why we need to move into these cleaner energy sources so that they can help improve the air quality.
Yeah.
There are some challenges that are a little bit harder based on geography. We have an extremely warm climate here, to say the least.
Yeah.
And we're situated in a valley, so that's part of the ozone issue. But there's a lot of things that people could do, just to try and move away from some of the sources of pollution. And so, there's a lot of conversation going on about climate change and how it affects the environment.
Right.
People don't talk about how it affects your health, and it does have an effect on health. And so that's why we get involved in these coalitions. We want to have a seat at the table so that we can educate people about the health effects as well as the environmental and the economic effects.
Yeah, absolutely. That definitely is an important component. Do you see things changing more? Like what do you see the long term looking like?
Yes and no. I mean, we work with a lot of organizations and a lot of companies that are building out sustainability plans and moving towards, having all electric fleets for their companies, or,
right.
Utilities providing cleaner energy sources. Not everyone's timeline is exactly the same, unfortunately.
Right.
But again, I think it's important that we all have a seat at the table and are part of the discussion so that we're moving towards similar goals. I mean, obviously, we would love to see, zero emissions everywhere as fast as humanly possible, right? Because we know the impact it's going to have on everyone's breathing and everybody's respiratory health. That's not, we can't wave a magic wand. So we need to work on these things with people, and we need to really talk a lot about why is it important for your lung health.
We want to help find lung cancer before you even have symptoms, so it can hopefully be cured. Ask your healthcare provider if lung cancer screening is right for you.
So now that we know that 10 to 20% of all lung cancers occur in non-smokers, that leaves the 80 to 90% of lung cancers occurring in smokers. And men who smoke are 23 times more likely to develop lung cancer than non-smokers, and women are 13 times more likely. On top of these numbers, Black men are about 12% more likely to develop lung cancer than white men. And overall, Black lung cancer patients are diagnosed with lung cancer at a younger age and with more advanced disease. With all of that being said, I called Dr. Scott Brandman, a thoracic radiologist and the director of thoracic imaging at Arizona Diagnostic Radiology. Because if you are a smoker, you should know how you can screen and what you can do to stay on top of your lung health. So as we're talking about lung cancer, I wonder if you could tell me a little bit about how you screen for lung cancer specifically.
Sure. So lung cancer is best found using a chest CT examination. And we use a low-dose radiation technique. So CT uses X-rays to acquire images of the body. And because this is a screening test and it's something that we will repeat over time, we use a special technique that uses a very low level of radiation exposure. So it's perfectly safe for people to undergo every year over and over while they're in this screening period to make sure that they don't have lung cancer. And when a patient comes to our imaging facility to have the CT examination done, it is really the easiest test that you can imagine. All that you do is you lie down on your back, you hold your breath for 5 to 10 seconds while you're moved through a small donut-shaped machine, but there's no tunnel or feeling of claustrophobia. And after that, it's done. There are no needles, there's no contrast or x-ray dye, there's no fasting beforehand. It's a simple, painless test that really slashes your risk of dying from what is the number one cancer killer in the world, lung cancer.
Yeah. So who would want to have this screening?
So the guidelines for who qualifies for a lung cancer screening exam were developed by the United States Preventative Service Task Force, and they recommend screening for anyone who is 50 to 80 years old, who have a significant smoking history, and who have smoked at some point in the last 15 years. And your healthcare provider can help you determine if you have a significant smoking history, but it's defined as at least a 20-pack year history of smoking, which is the equivalent of 1 pack a day for 20 years or 2 packs a day for 10 years, for example.
Oh, wow.
But it's really important for people who are currently smoking cigarettes to realize that lung cancer screening is appropriate for them, because there's absolutely no shame here. We understand that smokers have developed a habit, and your healthcare provider can share resources to help you get away from that habit. But in the meantime, screening for lung cancer should not be delayed.
Right.
And it's also really important for people to remember that lung cancer screening is not a once and then done thing. It needs to be repeated every year. So if there was an abnormality found, it can be followed up. And because lung cancer can develop over time. So the first scan might not show anything, but a scan done years down the road might show a new lung cancer. So that's also important to keep in mind.
Yeah, that's what I was going to ask you about, because you mentioned about doing it yearly. Is that like, if you've been a smoker or are a smoker, is that just an indefinite thing that you would do every year?
So the United States Preventative Service Task Force recommends that you continue with that screening every year as long as you're in that age window of 50 to 80 years.
Got it.
And it's important to remember that the test is fully covered by Medicare and Medicaid. They cover the exam between the ages of 50 and 77 years of age. And most private insurance also covers this 50 to 80-year-old window. Usually with most private insurance companies, there's no copay for people who are at high risk for developing lung cancer. So again, a simple, painless test. It really does a fantastic job of preventing you from dying from this number one cancer killer. It's covered by insurance. I think this is really something that people need to pay attention to.
Yeah. So I was just reading actually a study that said that overall adherence to lung cancer screening follow-up after a positive low-dose CT exam is less than 50%, and even lower among men, current smokers, and Black people. So I'm just wondering, what do you think about that?
So any screening test can provoke a feeling of anxiety.
Right.
And some people who have developed this habit of smoking, they feel a little bit of shame sometimes, and they don't want to have people telling them that they need to quit or that they've done something that might have damaged their body. And that's why it's so important. And everybody on our team at Arizona Diagnostic, we are this no shame environment. There's no reason that anybody should feel embarrassed or anxious about having the test done, because actually the vast majority of lung cancer screening exams don't show lung cancer.
Yeah.
So the majority of people will get this wonderful letter in the mail and will receive wonderful news from their ordering provider, their primary care healthcare provider, that the test does not show lung cancer. And that is fantastic news to share with the vast majority of people. And we get to share that great news with them year after year. But for some people in this high-risk group, sometimes there is an abnormal finding that does require follow-up. And when we get into that situation, it's normal for people to feel a bit anxious about what did we discover and what might this mean. But the beauty of participating in a lung cancer screening program is that when we do find something, it's usually because you're asymptomatic and we've found it at its earliest stage when there are the best treatment options.
Sure. Yeah, I'm sure there's a lot of stigma attached to that because I don't know that the same is true for other kinds of cancers. Right. Would you agree? Yeah.
Yes, you're absolutely right. But that's why I want to encourage anybody who is even currently smoking to not feel this sense that they don't deserve to participate in a screening program.
Right.
Because their health is equally as important as everybody else. We realize that they picked up a habit. When they picked it up, they probably didn't realize that this was going to become something that they would do for many, many years. And they probably didn't even realize the potential health consequences to it when they started the habit. And so there's absolutely no fault. But yet there are some very strong risks associated with the habit. But we have this wonderful screening exam that can help us find the disease before it's symptomatic. And that's why it's so important. If people who are feeling anxious or shame, if they wait until they develop a bad cough, or they wait until there's a little bit of maybe blood in their phlegm, or they're short of breath, or all of a sudden they've been losing weight unintentionally. Those are signs that maybe they have lung cancer at a more advanced stage. And for those people, it's harder to cure lung cancer at that point. Whereas if we screen people without any of those symptoms that we were just talking about, if we do happen to find lung cancer, we will find it when it's tiny. And there are so many excellent treatment options that can cure the disease. And so that's why there should be no shame or anxiety. People who are at high risk because of their smoking history should undergo their annual lung cancer screening exam so we can find the disease when it's early.
Right. And then, so you were talking about early stage versus a later stage in terms of physical, things that happen to you physically. And what does that look like in your lungs?
Sure. Unfortunately, if a person is not undergoing annual lung cancer screening, we're not going to take pictures of their lungs until they're developing those symptoms that we were mentioning, because that's what's going to make them or their relatives or their friends concerned. They'll then go to their healthcare provider, have a chest CT ordered, and it's in those patients where we end up, unfortunately, finding later stage disease. And what that looks like on the images, the x-rays that we generate, the cancers are bigger in the lung, larger in size, and they've often spread to other parts of the chest and sometimes even other parts of the body.
Yeah.
And so that's why we don't want to wait until you've developed symptoms. We want to take these pictures when you have no symptoms, because that's when we find cancer in its smallest, earliest stage. And at that point, 70% of patients who are participating in screening, if we do find cancer, 70% of them are at these earliest stages. And that's when treatments are so incredibly advantageous today and can often cure the disease.
Lung cancer is no longer sort of the grim, the very, very dour diagnosis it once was. It is a field exploding with science and with advances, with a lot of enthusiasm. The stigma really should be off the table. Healthcare providers are very, very attuned to the signs of lung cancer, and CAT scans are safe.
If you've listened to any of our past episodes, you might be familiar with Dr. David Hoffman. He's the medical director of Tower Hematology Oncology and a professor of medicine at Cedars-Sinai in Los Angeles. He's become my go-to source for cancer-related information because not only is he a wealth of information, But he also has this amazing optimism about treatments and cures and the future of cancer research. And I always come away from our conversations feeling really hopeful, even when we're discussing something that could otherwise be depressing. So I called Dr. Hoffman because here we are again talking about cancer.
Lung cancer, as you know, is number one, extremely common and highly lethal. And so it's a sort of a bad combination. And historically and traditionally has not received the kind of research funding that other tumors have enjoyed. So it's been a bit of a catch-up game in lung cancer. And I'll give you an example. So there's one kind of lung cancer that is different than all the others. Like most cancers, lung cancer is really a group of different cancers.
Right.
But there's one kind that really stands out as a different disease. It's called small cell lung cancer. And then there's every other kind. And every other kind gets grouped together in one heading, which is non-small cell lung cancer. And the reason this was the case historically is even though we knew they were different diseases, we treated them all the same. And that speaks to the fact that there really just wasn't enough resources put into the research to try to help understand the biology and the management of non-small cell lung cancer. As time has gone by, we've gotten much better at differentiating the treatments based upon the different subtypes of lung cancer. But lung cancer really didn't get the due it was needed for decades of time, and so it's been a catch-up game.
Interesting.
So lung cancer is really a disease of exposure, and the classic exposure is tobacco. But in North America now, most lung cancers, especially most lung adenocarcinomas, which are the most common subtype of lung cancer, are in non-smokers or never smokers. And that means that it's other exposures in the environment that must trigger this. We know some of them, things like radon or asbestos, but the truth is we don't know enough about what the exposures are. So I think like most malignancies, there's probably a series of exposures, environmental exposures, whether they're infectious or they're toxins or they're autoimmune or whatever they are, that will stimulate a response and coupled with a predisposition. And that's why some people who have tremendous exposures to carcinogens never get lung cancer because they don't have the predisposition. And others who you have a hard time sort of understanding their exposures do get lung cancer. But lung cancer, at least the traditional tobacco-associated lung cancer, is an eminently preventable disease simply by not smoking. That's like if of the few things we know with respect to lifestyle modification, avoidance of tobacco is a big deal, and would prevent a significant amount of morbidity.
Right.
But I think that there's a lot of mystery, and patients really ask. These are practical questions that patients want to know. What do I do to prevent lung cancer? What do I do to prevent a recurrence? How can I modify my lifestyle? And we're just not that good at it yet.
Yeah.
But I think that this is truly an exposure-driven tumor along with a predisposition.
That's interesting that you say that because one of the guests that I spoke to earlier today, she is a survivor. She had stage 4 lung cancer and realized that there was a high level of radon in her house. No one else in her house got cancer, and they discovered that neighbors also had even higher levels, but no one has gotten sick. So she, doesn't understand why she did, but that's interesting that you say that.
It's a perfect example of that, right?
Yeah.
Where everyone has a common exposure, but only some people get the tumor, and we're not that good about the biology yet. And I think as we get more and more into, understanding the genome, I think those will become clearer. But as of now, it's still kind of a poorly understood risk.
Yeah, and I was reading something also that they think now there also could be a genetic component, which seems sort of new for lung cancer.
Yeah, I think there certainly is a predisposition that's based upon genetics and upon the genome. And so I think as we start to understand that better, and as the science, so it used to be that to sequence a genome was $1 million, and now you can do it for a couple of $100. And so I think that as we get access to more people's genomes and understand the patterns of exposures and how they match up with genetic predispositions, we'll get a better idea about, the algorithm that it's going to take to try to find who's at higher than average risk.
Right. Yeah. I mean, I guess it's one of those things like we talked about HPV. It's kind of scary though, also to just think like, well, I could be breathing something every day and maybe it'll give me cancer. It's just another one of those.
It's totally unnerving. And the truth is, breathing city air, which is where most of us live.
Yeah.
If you look at CAT scans of people's lungs, almost everybody's got little spots in their lungs, and you just hope that they're benign, because it's really hard to know when are those little spots real and when are those little spots malignant or precursors to cancers. And we all breathe toxins all the time, and so it's really tricky.
Yeah. Ugh, that's crazy. What do you know about vaping? Because from what I read, there's nothing really conclusive about that.
Yeah, I think it's just too soon to know. I think that there's a better science in terms of lung injury with vaping than there is with malignancy. Mm-hmm. And I think that people vape a variety of different substances, as you know, including tobacco and cannabis and other things. So it's hard to argue that vaping's good for anybody. Right? That would sort of be a stretch. Yeah. But I don't think there's a good science yet to say what the risk is in terms of a malignant change.
Right. So in terms of lung cancer detection, I mean, we know that there's a criteria for high risk patients. They can do a low dose lung CT. We've talked about that with our director of thoracic imaging, which I guess is a really great tool for detecting cancer in high risk patients. But what else is there? And what about people who are not necessarily high risk but concerned? What other?
Right.
Yeah.
And right. So it's sort of a super complicated public health question. So there used to be an interest in doing sputum cytologies, where people who were at higher than average risk would make a sputum sample and then look for cancer cells in the sputum. And it turns out that had pretty low sensitivity and was hard to, people basically would just spit in a cup. And if you didn't get like a real sample, it wasn't good. And so that was never that high yield. And again, with the advent of modern CT scans and their, ubiquity, everyone has an opportunity to have a CT scan, even those who are at sort of average risk. There's an equation that has to be done in terms of cost and risk, in terms of benefit, at the macro level, which is hard to figure out. There's also the exposure question. So lots of patients are concerned about the exposure to ionizing radiation that come with CT scans. And it doesn't matter that you explain to patients that the exposure is really sort of trivial. There's hesitancy. So, and there's sort of a societal stigma that comes with smoking. And so people who are smokers sometimes don't want to, discuss that or sort of aren't that proud to sort of think about it. So it's not exactly clear who at the primary care level is getting CT scans. The truth is, at least from a cancer perspective, the ones that we end up seeing that have early stage disease are the ones who were lucky, but not the ones who were smart, but the ones who were lucky. They had a scan for another reason, or they had, a symptom that somebody had a very high level of alert to investigate, and they were found to have an early stage lung cancer most of the time just by happenstance. And, that's not great. It'd be better if it was intelligence that picked up early stage lung cancer, is not good fortune. Yeah. But a lot of times it's really just being lucky, not being good.
So for the most part, it's caught later stage lung cancer.
Correct. Right. Lung cancers usually don't cause symptoms until they're very advanced. And with rare exceptions, they're incurable diseases. So, most of it, and it's interesting because most of the revolution in the therapeutics for advanced lung cancers, and there has truly been a revolution over the last 20 years, is really about managing advanced disease, not curing the disease. So, the surgical advances have been technical. So there's been a significant change in the surgical techniques to cure lung cancers. So, what used to be very large thoracotomies and very, very difficult surgeries are now almost always minimally invasive surgeries, done with scopes, and highly effective. And still, most standard thinking is that the only pathway to a cure for lung cancer really goes through an operation. Right. There are exceptions. but that's really the standard thinking. And that in advanced disease, there's been a true revolution in the therapeutics and a movement away from chemotherapy. And that's been sort of a very welcome change in our world.
Right. Oh, yeah, for sure. Do you think that advances in this particular kind of cancer have moved slower than other cancers?
They started off behind, so there wasn't like an even starting point. So
right.
They started off way behind. But the natural history of lung cancer is such that you can really get a good idea about the course of a patient's illness from presentation to sort of the end of their lives in a relatively short amount of time. So making impacts on survival can happen faster than you can see in things like breast cancer, which, people survival is measured over many years typically. Right. Historically, the survival in people with advanced lung cancer was only measured in months. And because it's a common disease, it's sort of a good model to study. And with the advent of modern treatments, there's been sort of a nice catch up. And so there's been so many new therapeutic advances in lung cancers, even though they started off way behind other cancers, they've caught up nicely.
Right. Interesting. And I think there's also, from some of the other conversations I've had, this stigma issue with the smoking and it being a smoker's disease seems to be an issue with lung cancer.
That's true. It's sad to say, but if someone's a heavy smoker and they get lung cancer, people will look at that person and say, "You brought this upon yourself, or you deserved it." Mm-hmm. And that's a harsh thing to say. Yeah. I think that many people who have lung cancer were exposed passively to smoke. Many again were never smokers. It does have a connotation as being sort of a self-inflicted cancer. And I think that inhibits it inhibits patients from being screened. It inhibits patients from being caught in early stages. So it's not a very helpful distinction.
Yeah, and I was reading. I read something that said that adherence to follow-up screenings or treatments after a positive CT exam is less than 50%. So
I think that's right. And I think it's hard so patients don't want to be told, especially active smokers, they don't want to be told to stop.
Right.
And physicians don't want to be in the position of trying to admonish or lecture to patients or to, so it's a sort of a strange thing in terms of a lifestyle. And it somewhat defies understanding why there's still this persistent acceptance of tobacco in the community and why, young people still decide to smoke. Those things are sort of beyond the level of standard understanding. It's more of a psychological question. Yeah. But follow-up and adherence to follow-up is not great. And it turns out to be a little bit more of an adversarial cancer in some ways than others. So one of the joys of oncology as a medical practice is that you really are a partner with your patient. This is one of those where it's a little bit less of a true partnership sometimes with the patient. Sometimes it's a bit more of an adversarial relationship.
Right. That's really interesting and sort of sad also.
Yes, I think it's a tragic problem, and especially given the lethality of lung cancer, and the potential, for curing this disease or for early stage detection, we could do better.
Right. Yeah, that is unfortunate. So what about, let's talk about what's the future of lung cancer treatment?
Right. Well, the future in some ways is now. So there's been a couple of dramatic changes in the treatments, and that's again moving away from standard cytotoxic chemotherapy and moving towards two different realms. One is immune therapy. So immune therapy has made a dramatic impact in lung cancer. In a subset of patients, it has provided long-term durable control of advanced disease. With nothing like the spectrum of side effects that chemotherapy brings, right. And so it has changed the playing field for a number of patients. And even though some of the mechanisms of immune therapy are somewhat counterintuitive to what you would think with respect to treating people with advanced cancers, it can be a mainstay of treatment. There's an issue with respect to the societal cost of immune therapy. So with rare exception now, immune therapy is kind of the standard of care rather than the exception of care. And it's hard to know exactly how society can cover that cost. It's an extremely costly treatment. But immune therapy has made a dramatic impact scientifically, and patients truly embrace the idea of a treatment that enhances their immunity rather than just poisons their body.
Right.
And then the other pathway that's really become dramatic has been the advent of targeted therapy. So for a number of lung cancers, there are identifiable mutations that provide therapeutic targets that can be managed with oral medications that are not chemotherapy, that specifically target the mutation of interest and can provide incredibly useful and helpful treatment responses. So this is truly one of those kinds of cancers where you find the treatment that will fit the patient, and the word lung cancer becomes very secondary, and it's much more about what is the mutation pattern, where are the weaknesses that we can exploit, what are the strengths that we should avoid, what are the defenses, what we need to know about, and you avoid giving treatment to people who are not going to benefit, and you enhance the group of patients who will benefit by giving these specific targeted drugs, and they make a tremendous difference. It's still the minority of patients who have these mutations, but the number of mutations is growing that we know. The number of therapeutic options has grown tremendously, and these are very convenient drugs. They're not chemo. They're oral medicines. People take them at home. They don't lose their hair. They don't get sick. It's really a remarkable thing to find one of those activating driver mutations.
Wow. Yeah, that's something the survivor that I spoke to mentioned, that she had tested for one of the mutations, so was able to take one of the medications. I didn't realize that existed with lung cancer. So.
Right, and there's a number of them, and the only pathway to long-term stability is either through immune therapy or through a targeted drug. Chemotherapy just can't do that. So, it's truly the silver lining. If someone has advanced lung cancer, if they have a mutation that is a driver, then there's a target, and there's a therapeutic drug that's designed and engineered specifically for that mutation.
That's so interesting. And I know we've talked about immune therapy on previous episode, and I just wonder, at some point, do you think that costs would come down or insurance would cover it? It seems like it's being used for so many different things.
Yeah, I think the market's going to have to allow for that. I mean, I know that pharma has an interest that is overlapping with those of patients, but it's not totally convergent. And I think that with market forces over time, costs will have to come down. I think that that's just always the way that those kinds of things work. And of course, newer therapeutics will replace them. So there's this treadmill effect where you keep on finding new things. They eventually become a bit more affordable, and then you find newer, more costly interventions. And it's incremental progress, but it is real progress. And we're seeing it in our lifetimes, and it's on a sort of an every year we're getting new weapons, new treatments. So it's really an exciting time to be a lung cancer oncologist. The number of clinical scientists and translational researchers has exploded. So really smart, talented people are putting focused energy into this disease, and it's really paying dividends.
Right. That's great. I mean, I did read actually another thing that said that in 2021, there were more than 10 new drugs approved for lung cancer alone, which is pretty remarkable.
Yeah, it's extremely remarkable. The pathway to new drug approval is typically laborious, slow, and very costly. And to get 10 new drugs, in a single year approved that's revolutionary from our perspective. Yeah,
that's great. So do you see, I guess in the patients that are getting treated, and do you see survival rates or years are increasing?
We do, for sure. So historically, in advanced lung cancer, at the research level, where people were flying in from out of town to go to research centers for treatments, the response rate was about 1 in 3, and the survival was less than a year. And those were for responders.
Yeah.
And now it's routine for people to live for years and have high quality lives and never even see chemotherapy. So it's change the game completely.
That's amazing. Yeah, so that's great, and that's, I think, what people should hold on to. And then so someone who's maybe early stage and what are things that people should look for, so that we can not have so many late stage people coming in?
Right. So I think people need to certainly identify if they have a risk factor, such as exposures like tobacco use, right? And so they should feel open to saying, "Look, I need screening."
Right.
In terms of symptoms, we know typically it's cough, but cough is such a common symptom. But coughing up blood, we say hemoptysis is a big red flag. So a persistent cough, a cough that's productive of blood, chest pain that doesn't go away. Those are symptoms that are alarming enough that one should seek attention. Yeah. And because it's so easy to image the thorax now, it would be a very, very useful and effective to find an early stage cancer. Yeah. So, there are some physical signs. One of the things that we look for is on people's fingernails, actually. If their fingernails start to become clubbed, where they get rounded at the end, that's a sign that there's something wrong in your lungs, and we would want to check it out.
Oh, that's interesting.
But it's not a very common sign, but it's certainly that's something that you'd want to tell somebody about.
Yeah.
But really, it's mainly symptoms confined to the chest. So it's changes in breathing, persistent cough, chest pain, or coughing up blood.
Okay. I mean, I guess that's the kind of thing. I know this last guest I spoke to, she thought she had asthma. She thought it was allergies. Like, it took her a while to really seek any kind of treatment. She was also a non-smoker. And
you certainly can't fault them. There's so many things cause cough, and no one wants to be an alarmist, and no one wants to jump into a CAT scanner. So there's a balance, but early stage lung cancer is a curable disease.
Right.
It's critically important to find it early, if at all possible. So one should have their radar, somewhat more sensitive to this kind of a diagnosis.
Yeah. I mean, I guess it just comes back to just listening to your body, and being aware of things that just don't seem right.
Agreed. Right. I mean, and no one wants to be hypervigilant, so that again, it's tricky, but I think being sensitive to your body without sort of crossing the line into hypervigilance,
right?
And partnering with your caregiver, those are the things that you want to do.
While I was editing this episode, a study was published regarding low-dose lung CT, which is the screening that we talked about with Dr. Brandman. And I want to share some of those findings. For one thing, the study showed that only 5% of people who are eligible for this screening are actually receiving it. 5%. That is astonishingly low. The study also showed that of the patients in the study who were eligible for screening and who screened, only 22% of them continued on with annual low-dose CT screenings, despite the fact that it's recommended to have them yearly. The really important thing found in this study is that when consistent screening is implemented, there is a significantly higher rate of stage 1 diagnoses of lung cancer and lower rates of stage 4. And this is insanely important when you look at another study that showed that patients diagnosed at an early stage with low-dose CT screening have a 20-year survival rate of 80%, which is huge. So let's look at everything we've learned from this episode. If you're a smoker, or if you quit within the last 15 years, the best favor you can do for yourself is talk to your doctor to see if you qualify for screening. Forget stigma, forget blame, forget guilt. It is what it is. And now you have to do everything you can for your own health. If you're a non-smoker, there are still environmental risk factors out there. And if you don't want to live your life in a plastic bubble, the best things you can do are be as healthy as you can in your diet, exercise, and stress levels, as Marissa told us. And if you're really concerned, You can look into getting involved with the Lung Association. They've got all kinds of events and volunteer opportunities. Their website again is www.lung.org. I think for me, my biggest takeaway from all of these conversations is to just talk about screening. Like, if you know someone who smokes, tell them about it in a really nice, non-judgmental, caring way, of course. Tell them to listen to this episode. Let's just spread the word about screening, which now we know saves lives. Let's just do whatever we can to get closer to a world that is cancer-free. Thanks for listening. If you've enjoyed our podcast, please be sure to download Your Body Show for more great content and leave us a review. We'd love to hear from you. If you want to learn more, visit yourbodyshow.com or check out our social pages on Instagram and Facebook. Search for RadNet California. Your Body is produced by Steve Kramer, Doug Smith, and me, Stephanie Landon. Joseph Wilson is head of technical production. Executive produced by Paul Colacchio and Karen Morad, all on behalf of RadNet. Original theme music by Mark Lakier. We hope you've enjoyed our HealthCast. Find us wherever you download podcasts.